And once his lab came back, I'll bump back really quick. At 111, they stopped it. Makes sense. He received a whole bunch of DDAVP while he was there trying to fix that rapid correction. He also received lots of D5 at an equivalent rate or slightly above his urinary output, just to try to help prevent that endogenous overcorrection. Admit to DC was 4 days. So let's evaluate this a little bit. The 2024 practice guidelines say for patients with high risk of osmotic demyelination syndrome, which there's a couple of factors that make you high risk: alcohol use, hypokalemia, malnutrition, and a sodium of less than 105. So he's clearly high risk just when we saw him. So high risk, you want to correct by 4 to 6 milliequivalents a day in the first 24 hours and no more than 8 in any subsequent day after that. So if you go by the recommendations for high risk, you can see at 24 hours, we should have been at 109, we're at 112. Doesn't look too bad, but if you look between there, we went all the way up to 116. At 48 hours, we should have been at about 114, we're at 116. Also doesn't look too bad there, but he went all the way up to 123 in that time frame. So, and on day 4, which was discharge, we should have been at 124 and we were at 135. So, and there was really nothing that could be done about that. We were giving him a bunch of D5 to try to fix that, because that's just that endogenous overcorrection, fixing that hypopituitarism and everything, and the adrenal insufficiency. That was just him recovering. If you were to follow the general recommendations of less than 10 and less than 8, it does look a little bit more safe, like if we were within a better window than we actually were. And then endogenous overcorrection was what we were fighting against here. So he discharged, you think everything's great, but he's back in your ER. It was 9 days since you saw him. He was discharged 4 days after his original encounter. He presented to the ER 2 days prior, so 3 days after discharge, with general malaise, sluggishness, and weakness. And they saw him, they discharged him home, thinking it was just a diagnosis of weakness with strict return precautions. You know, he had a bunch of stuff going on, so they weren't overly concerned. His mother, however, on the East Coast, was talking to him on the phone and said he is not acting like himself. So she flew all the way out from the East Coast as soon as he was sent home from the ER and brought him in. So this is when you're seeing him again, 9 days since his first presentation. He's now drooling and unable to control his own secretions, and states part of his body aren't working well. So here we go. Osmotic demyelination syndrome. So one major clinical pearl is just don't forget the basics, consider the cause, and we don't want to overcorrect. And since he's most likely going to endogenously overcorrect, we got to try to, dilute that out as much as possible. So as much D5 as you can get in there. And the symptoms of ODS start anywhere from 2 to 6 days post overcorrection. When he was admitted the second time, when he came in with the drooling and everything, he was given 40 grams of IVIG daily for 5 days. So that's 400 mg per kg. And just a reminder, so this is just his lab progression over time. When he hit here at the admit the second time, he was admitted with a sodium of 122, 123. And I have a feeling that's probably where he lives at baseline, just with his adrenal insufficiency. So where is he now? He has a confirmed diagnosis of extrapontine osmotic demyelination syndrome. He was here for about a week, and then his mother took him back to the East Coast to see a specialist, I believe. She took him to Mayo Clinic. He underwent intensive PT-OT. He still has persistent lower extremity weakness and muscle cramping, but he is independent with his ADLs, However, he can't live independently at this time. So he's still with his mother back east. He cannot move back out to Maui and live independently. He has minimal speech impairment. He has some impaired articulation and some distorted consonants. And one thing that the specialist did that I did not consider, which makes perfect sense now at the time, is he prescribed dexamethasone 4 milligrams IM as needed for adrenal crisis or intractable vomiting. And this patient said he never had an experience like this, so he was educated on how to use that and kind of what to look for moving forward. So, and that is that. So, for my first assessment question, what is the recommended correction rate for chronic hyponatremia with a low risk of ODS? Good, we're in D. So 10 millimoles, that's for chronic hyponatremia with low risk. And don't forget that increased risk is less than 8. And how long after overcorrection can symptoms of ODS present, typically? Go work, everybody. 2 to 6 days. I do say typically because after reading into this more, I found that it can appear on MRI up to 4 weeks after symptom onset. And they can actually see it on MRI in asymptomatic individuals. So I found that kind of interesting. And this patient actually, after I put this presentation together, I went back and looked, and his MRI, we couldn't really see it when my doctor and I were looking at it. The specialist, though, said that he did have clear symptoms of it when he presented in the East Coast. Okay, so what questions does everybody have? I did see one. Let's see here. Dexamethasone instead of HCT. I don't know. I honestly don't know that. If anybody does know that, please feel free to log it in the chat. Yep, mineralocorticoid activity, probably.
Looks maybe because of the Betsy, Nick Filk was saying maybe because of the nausea and vomiting using dexamethasone, maybe.
I would, yeah. I mean, because most likely if you're going to have adrenal insufficiency, you're probably going to have some nausea, vomiting going on. And actually, Brittany said she can't believe I saw a case like this. And after doing some research on it, a sodium of less than 105 is super, super rare. So the Nephrology Association would like anybody who sees it to actually send in all of the case details they can, no matter what the outcome, just so that they can expose, like just study it more.
And I'm impressed that the patient survived. The cases that I've seen, the patients unfortunately did not survive. It sounds like they had some unfortunately negative outcomes for them, but like I say, the 2 cases that I've seen did not survive.
Yeah, I'm actually impressed. He really had a good outcome. Yes, he has a little bit of motor and speech issues, but he's probably going to be just being able to live independently again.
And Ryan brings up a point: no 3% for asymptomatic patients, and that's one thing I was wondering. Like, would you recommend now looking at this after the fact, not giving it or giving a lesser dose, or?
I wouldn't have given it at all. I did not want to give it just because I thought that that might happen and dump his sodium a little bit more. And taking him down to 101, I just made everybody in the hospital panic. So,
Yeah, it's definitely scary when people will get out their calculators or estimated sodium deficit and be so focused on the numbers that they're not thinking of the overall picture.
right. And that's exactly what my ER doctor and my nurse were doing because he went to the bathroom and she was afraid he was going to seize in the bathroom. So she like went in and grabbed him and brought him back. And I was like, I don't think we have to worry about that right now, but we don't know yet. And then we got into it and found out no, just a little chronic problem. And yeah, the electrolytes are, people are commenting in the chat about seeing all kinds of sodium problems, and electrolytes are scary. Sodium of 94, Nick, that's crazy.
Yeah, fun fact, he left AMA from the neuro ICU 5 days later.
Wow. Chronic problem.
Beer potomania.
Mm-hmm.
Needed to go get a 6-pack.
Nice. Okay, anything else, guys? Turn it over to Nick.
Thanks, Betsy. Appreciate that. Great case.
Thank you.
Yeah, everyone, can you see my slides?
Yep, good to go.
Okay, everyone. So my name is Nicholas Filk. Hold on. Technical difficulty here. There we go. Okay. So I'm going to be presenting, it's hot in here, malignant hyperthermia. If you get the musical reference, that's great. You're probably a millennial, maybe Gen Z. If you don't get the reference, well, please just look it up. It's great. No disclosures for me or anyone involved in the case. Objectives, insert your generic objectives for presentation here. So let's talk about the case and get into it. So a 74-year-old male presents to ED unresponsive via EMS. Found on the side of a road in a car, not responsive to stimuli. I wish I saw the full EMS report because I bet you $10 that PD probably shoves 2 Narcan into this patient's nostril, but I do not have that on record. So the patient was unresponsive on presentation, irregular respirations, GCS of 5. Patient was intubated for airway protection, so was given etomidate and succinylcholine at 7:03. Just remember that time, 7:03. Unfortunately, on the CT scan, there is a very large intracranial hemorrhage that was on there. I do not have the image, unfortunately. So as far as the case, so succinylcholine given around 7, I think it was 7:03, 7:23. Vitals, all of them were stable. Temperature 99, nothing to cry about. Heart rate 110, respirations 20. 3.5 hours later, though, however, after the succinylcholine administration, 11:04, temp was 107.2, heart rate 138, respirations 28, and then the end tidal was 69. It's supposed to be a CO2. Apologies, missing the C there. Serum potassium went from 4.2 to 6.2, not great. We also see the creatinine kinase from 1251 to 45068, and lactate 5.7, the serum creatinine 1.46 at 2.56. Not good at all. So let's talk about malignant hyperthermia. Well, what are we talking about malignant hyperthermia? It's like, I thought that was a thing we always mentioned in our RSI topic discussions. Like, oh yeah, just remember succinylcholine. If they have a history of malignant hyperthermia, don't give it to them, or family history of it. It's like, okay, sure. What happens if you don't know that information? It's great if you know it, but how many times can you talk to someone who's getting RSI and ask them, hey, do you have a history of malignant or family history of malignant hyperthermia? Probably not going to get that. So we have a hypermetabolic crisis, usually related to succinylcholine, but also volatile anesthetics. I feel like anesthesia hones on this a lot more when they're talking about, but maybe not so much from an ER perspective, especially from the ED physician perspective or provider perspective. It usually occurs 1 to 100,000 administered anesthetics, so it's pretty rare. It's an autosomal dominant inherited trait. All ethnic groups are affected. Previous uneventful exposure to a triggers an error, and it's all parts of the world. So pathophys, I'm not going to go too deep into it. Just know it has to do with the ranidase receptor 1 gene, and there's a mutation to it, which again, anyone who is then receiving any of these polarizing paralytics or volatile anesthetics can then, as a fulminant increase of muscle cell metabolism, which then leads to oxygen consumption, excessive CO2, and heat production, which leads to our malignant hyperthermia crisis. All our bad things: the muscle rigidity, the hypercapnia, the hypoxemia, the acidosis, rhabdo, hyper-K, and hyperthermia. So clinical signs and symptoms. So the one we're going to pretty much focus on is the fulminant malignant hyperthermia. It can occur as quickly as 30 minutes after a trigger event administration, muscle rigidity, high fever, and increased heart rate. Late onset malignant hyperthermia, I'm not going to focus on too much because this is more related to like usually in the OR with prolonged like inhaled anesthetic use. So we're just going to kind of leave that one to the side for now. But early signs, again, increased end-tidal CO2, muscle spasm, muscle rigidity, tachycardia, mixed metabolic or respiratory acidosis, elevated lactate, tachypnea, hyperventilation, elevated temperature. Kind of pretty much all the things that we had. But unfortunately, this gentleman is all well. You also would notice the elevated creatine phosphokinase and also hyper-K, which we did see, which we'll get into the whole timing thing in a little bit later. Again, clinical signs and symptoms, like I mentioned, this is just all the values just to be aware of. So let's dive a little bit into the management. Again, discontinue the trigger agent if applicable. You want to hyperventilate these patients with 100% O2 if they're on the vent, which they probably are at this point since you gave them succinylcholine. Bicarbonate, 1 to 2 mg per kilogram as needed. I think that's supposed to be milliequivalents. My apologies. Dantrolene, 2.5 milligrams per kilogram IV, push, repeat as needed, and cool the patient. I cannot stress, if anyone is not familiar with this crisis and they need assistance or the ER doctor is not sure, there is a 24-hour malignant hyperthermia assistance hotline that is down there. If you call this 800 number, someone will help you walk through the treatment, because this is, again, an extreme emergency. If it's not corrected, it can be easily fatal. So let's talk about dantrolene. So it is the agent of choice or the only agent of choice to help reverse this, is the ranitidine receptor antagonist that inhibits the calcium ion release from the sarcoplasmic reticulum. Whew, that's a mouthful. Malignant hyperthermia crisis, 2.5 mg per kg IV, push over 1 minute, may repeat every 5 minutes. You can usually give up to 10 milligrams per kilogram to these patients. There are some cases where you might have to give more, but then they also say if you're giving more than 10, also suspect, is there anything else that we haven't ruled out at that point? And then after crisis, so after the symptoms start to resolve, then you're supposed to put them on this maintenance for about 24 hours. So it's 1 mg per kg IV every 4 to 6 hours. And then, or you could do a continuous infusion, which I personally have not seen, which is 0.25 mg per kg per hour continuous infusion for 24 hours. Again, as far as dantrolene side effects, nausea, thrombophlebitis, tissue necrosis, if it does extravasate, injection site reactions, dyspnea, respiratory weakness. Well, I guess we don't have to worry too much about respiratory muscle weakness since they're on the vent. Somnolence and dizziness up to 48 hours, loss of grip strength and weakness in the legs, drowsiness, dizziness, dysphagia. But hey, I'm pretty sure we want to give this because malignant hyperthermia has a mortality rate of 80% if dantrolene is not given, compared to 8% with immediate use of dantrolene. So I'm pretty sure all the risks, the benefits outweigh all the risk in this case. Okay, so I'm just giving this an example. So this is one form of dantrolene. So this is Rayanadex. So this is a injectable suspension. This is great if you have it because it packs a lot of punch, because there's 250 milligrams per vial, a very small volume, which is excellent if you actually have to give a full dose. We'll talk about the other formulations in a second. Just in case if anyone does mix it or never seen it before, it is orange. And yes, it looks like that like thick orange, almost looking type milkshake mixture. It is an injectable suspension. So please, it is okay if you can't see through it. It's an injectable suspension, so don't be worried about it. But again, very important to make sure you do shake it up before pulling it out of the vial. So again, going back to after crisis care, so dantrolene IV for 24 to 48 hours. Coagulation status, you want to watch out for DIC, again, correct with fresh frozen plasma or platelets as needed. Hyper K, correct it again as needed with calcium gluconate, dextrose insulin, etc. So if rhabdo and acute myoglobinuric renal failure, again, fluids as much as possible to help mitigate this. Mannitol, furosemide as needed. And then tachyarrhythmias, beta blockers, and amiodarone again as needed. So as far as the resolution, so they have to, it's kind of similar to, DK where we have to meet all these criteria before we stop the drug. We want to make sure they're metabolically stable for 24 hours. The temperature has gone below 100.4 degrees Fahrenheit or 38 Celsius, decreased CK, myoglobinuria is absent, and there is no more muscle rigidity. So back to this patient. So just remember all the timelines. We started these 3.5 hours. That was at 7:03. So now we're talking about 11:30-ish. Note that the dantrolene we gave, which was a 2.5 mg per kg, 190 milligrams for 2 doses. But note the admin times at 12:18. It took a very long time to get the dantrolene, and we'll kind of go a little bit into that, why that is also a problem and why everyone needs to be familiar where it is. Again, his end tidal improved, temperature improved, heart rate improved, and the muscular rigidity resolved after the second dose of dantrolene. Unfortunately, the patient did receive more dantrolene doses in the ICU. However, resolution was not observed and additional labs were not obtained because the patient was transitioned to hospice. This was not related, well, I can't officially say not related to this malignant hyperthermia case, but the patient had an unsurvivable intracranial hemorrhage per multiple disciplines and services. So dantrolene delay. So in this case, time is tissue/brain, as we're kind of doing the whole motto of stroke. I guess you can almost say the same with malignant hyperthermia. There was no dantrolene in the ER. Not anywhere, not in the machine, not in the kit, nowhere. There was no kit in the main pharmacy. This was my first time at this institution having a malignant thermia hyperthermia. It was actually first ever. But I wasn't, I thought that maybe we'd have a kit, and it's something I didn't look into back in my mind, and there was no kit for it. So where was the dantrolene? Well, it was in one of our 4 giant carousels in the main pharmacy, which then we had to go get and then finally take upstairs, and that was causing a huge delay. Another thing I want to talk about with dantrolene is the 250 versus the 20. Our institution carries dantrolene 250 injectable suspension. What if you carry the 20? Well, if you only carry the 20, this is wherein lies the problem, possibly. Our patient needed 190 milligrams, so that's only 1 vial of dantrolene. Great. If you have to use the 20 milligram vials, that's 10. And a little fun math down here, 20 milligram vial requires 60 mLs of sterile water to mix. Not fun to mix, so total sterile water needed, you need 600 mLs just for that 1 dose. And if you needed the full 10 mg per kg, you'd have 40 vials of dantrolene 20 milligrams and 2,400 mLs of sterile water. Just to think of the math on that one, I kind of laugh a little bit, but some people might only have the 20 milligram. So clinical pearl, so prompt recognition of malignant hyperthermia is imperative. I can't stress this enough that if it's not part of anyone's probably annual competencies, especially related to the ER, it probably needs to get tossed in there, because I know the OR hammers this down with staff, with anesthesia, practice drills, etc. But how many times do you think the ER is actually thinking about this? We give succinylcholine probably on a daily basis. And I think it's just absent in mind. Oh, it's just that thing that people mention. But I'll just remember malignant hyperthermia. Oh, I remember that word. Yeah. But no one really thinks that it can actually happen. And what does happen, again, it is critical that these patients get this as soon as possible, the dantrolene, because the mortality is, again, 80% with no treatment, and reduced to 8 with dantrolene. That's immediate dantrolene use. And also know where your dantrolene is. Do a dry run of a malignant hyperthermia crisis, orders, drug location, do you have a hospital policy, etc.? Does anyone respond from the anesthesia team to assist, etc.? So summary, malignant hyperthermia is a rare but life-threatening adverse medication reaction, Succinylcholine is common medication given to ED, which can cause MH. We give it all the time. Again, something that's in the back of our mind we always talk about, but it can happen, and clearly it did in this case. And delivery of dantrolene ASAP is key to patient survival. Okay, everyone. So we are going to jump into assessment question 1. What are the early signs of malignant hyperthermia? A, increased end-tidal CO2, B, hyperkalemia, C, muscle rigidity, or both A and C? Yes, I see these, both A and C. So increased end-tidal CO2 and muscle rigidity. Again, with the hyper K, that's typically seen as a late malignant hyperthermia case. In this patient, we'll talk a little bit more and get to the discussion of why maybe it was this case. Okay, second question, everyone. What is the initial dose of dantrolene to give to a patient with MH? 2 mg per kg IV push, 5, 1, or continuous infusion? Yay, everyone's listening. 2.5. Perfect. All these other ones don't make sense. 5 is double the recommended. 1 is for your maintenance, and the other one's another maintenance. Okay, so this one, I'm going to open this up. This is discussion items. I know there was a question. Let's see here. I'm going to go find it real quick. Okay, someone had a question. What decision making was involved in giving that second dose in the air? Did the hotline recommend that Justine can repeat if needed, especially if Virginia was resolved prior to the second dose? So the decision was made to give the second dose because we didn't see any resolved in symptoms. It wasn't a hotline recommendation. It was just us making a decision on the fly. Okay, and now is everyone, I just want to open this up to discussion. Feel free if you want to come off mute or if you want to chime in. So where do you keep dantrolene at your institution? Do you keep it in the Omnicell or Pyxis machine? Do you keep it in a kit? Looks like we have ED Omnicell. And now I guess also follow-up question, if you do keep it in your dispensing cabinets, do you have to have an order or is it on override? I see MH cart in Maine. Hyperthermia kits in the OR only. Override 100%. So again, I guess that also is a good question for everyone too, is, if someone has an MH card in one of our ED rooms, that's actually pretty cool. So I guess trying to make the argument is that, if you have a full cart, then people might argue what's actually worth keeping there versus anything, etc. But then do you have the dantrolene 250 or 20 or both? And I see some people only have a policy, no policy for outside the OR. That was another interesting thing too, because of my next question. Is there a policy outside the OR? Because I've been in an institution where we had a malignant hyperthermia for the OR, but then we also had a separate policy for cases that occur outside the OR in the event that it did happen. So we'd have like a kit in place, et cetera, and there'd be a special code called overhead, et cetera, to utilize as much resources as possible. And I see a lot of people only carry the 20 milligrams, which again, when you see like a tote of dantrolene, people don't believe me. It's like a tote where it's just like all dantrolene and all sterile water, and it's like a full like Cardinal or McKesson or whatever drug supplier tote you have, and it's just the drug and just the sterile water. It's a lot. Again, takes an assembly line of nurses to prep. Exactly. It's usually like a full line. I've seen people do it multiple ways, how to inject it, using dispensing pins and needles, etc., whatever's quickest to inject it. And then again, do you have any drills or competencies at your hospital? And do they include ER staff? I think someone over here mentioned, I'm scrolling through, there's a lot in the chat. Yes to drills and competencies, which is great. I don't think I see enough no drills or competencies, unfortunately. It looks like got their competency for OR only, which is, oh, it's the thing. It's just like, no, sorry, it feels like this needs to be more of a focus in the ER. It could be just me, but again, this was the first case I've ever seen. It might be the only case I ever do see, and some people may never see it. But again, it's just it happens so rarely. It's one of those things though that it's such an emergency and it's so imperative that they get the drug that again, we have to drill every time we are in our joint commission window. That one's a pretty good one. I like that one. Yeah, that's every time when someone drills. Oh, joint commission's coming. Let's practice all the stuff we haven't drilled in a very long time. Yeah. Okay. If there's any questions from the audience, you can come off mute if you need to.
I'm curious, Nick, if who else has seen? I know Betsy. It looked like she put in the chat that she had seen it, and they wound up running out of their IV dantrolene. So she said they, recommended oral, and just wondered. I said, hey, better than nothing, but I'm curious who else has seen it, because I feel in the emergency department we just won't be looking for it, unfortunately.
Yeah, and again, discussing back to this case, I feel like that's why there also was such a huge delay from initially. I'm not, obviously, I don't think the patient had a continuous temperature monitor in. I don't think they like insert like a Foley with continuous temperature monitoring. So I don't know how closely, we are actually monitoring the temperature, which is like one clear sign. Again, this whole goes to the whole pathway down. Oh, this person has like a severe intracranial hemorrhage. Maybe in mindset we're not thinking that too much is going to be going on, etc. But again, exactly how do you actually handle it? Uh, it's again education, which again I feel like there was a lack of that. After this, we kind of went around and educated all the ER doctors, and I think this is going to be kind of escalate to even more where is there like an actual policy where it happens outside of the OR? Because I feel like again the OR practices this so much, but not necessarily in the ER itself, which is again kind of scary because we give succinylcholine all the time. Maybe people give rock more, but yeah. Any other questions?
Hey, Nick. Thanks for this case. It was super informative. I was going to reiterate your point about the differential and making sure that we're ruling out other things because I had a case that I got roped into. A patient was intubated in the field with EMS for altered mental status, obviously. When they got to the ED, she had a temp of 107. And my physician's decision making was that he was concerned it was malignant hyperthermia because of the succinylcholine and that he thought the temperature was too high for infection. And
Uh-huh.
so we gave the dantrolene, consulted our toxicology service because we're lucky enough to have one of those in-house after we gave the first dose of the dantrolene in the ED. But turns out it was a raging meningitis.
Ooh.
So even though the temperature was 107, this patient just was floridly sick. And so that's just always a good plug to keep that differential in mind. Sometimes the temperature is that high because people, haven't been checked in or haven't been evaluated, and it just is allowed to progress.
Do they have muscular rigidity?
She I'm trying to remember. I think it was iffy because then there was also the question she had been down for a while, so she also had like extreme like purpura all over her body, and so then we were like, is the muscular like is she rigid from like being down, or is it from like the potential malignant hyperthermia? But I don't think it was anywhere near what you would expect from a true muscular rigidity. I think that's why we were kind of on the fence, but we gave the dantrolene anyway.
Gotcha. And I think, Ryan made a good point too. NMS and serotonin syndrome, again, you have to be careful with because, that especially if you don't know someone's like on like antipsychotics, again, the NMS could also be there. And also the serotonin syndrome. But again, good things to rule on the differential, which again, sometimes you have to work with what you have. Sometimes you don't have all the history. But yeah.
I think there was another question. I don't know if you saw in your research, Nick. Abigail Zener said that they had somebody that was on a calcium channel blocker Did you see anything about any drug interactions? I guess, would you change your dosing or any monitoring or anything for that type of patient?
In my research, I will admit I did not do a deep dive related to it because it wasn't related to this case. Again, if someone does have that info, I'm glad to be edified, but I was not sure about that one.
No, it's okay. It's the only case I've ever had, and it was very similar to, I believe, Brittany's case, where the patient was known to be septic, had a temp of like 101, 102 that skyrocketed up after getting intubated with sucks to like 107. But that was the discussion point that happened at the bedside because they were on diltiazem for AFib, because they were already in AFib before they came in. Is like, okay, can we stop this? What do we do? Because the theoretical risk is cardiovascular collapse. So the patient did okay with that sense of it, but I was curious if anybody has actually run into that situation previously, or if that was just a one really weird case that I had 3 years back.
I feel like it's so rare. It's like I don't know if you can even put an end to it.
But I appreciate the input.
So, did you guys actually give the dantrolene in that case or decide against it?
We did. We held it until we could stop the diltiazem, though. So yeah, and it took us a little bit to get the Ryanodex up anyway, so coincided with the time that we could get the drug up to the patient, and then we just had push dose epi at bedside in case we needed it.
And again, one question someone brought up and talked. So dantrolene used for a patient who came in very agitated, high temp post Molly use, rigid in the limbs. The RMD wanted to use dantrolene since he's aware of its use. The raising concerts need to do a deep dive into it too. I guess, has anyone heard of dantrolene use for Molly overdoses? Dantrolene use, and then someone else replied, just like Jerry replied, given dantrolene use in cardiac arrest. Not quite sure about that one. Okay, everyone, any more questions? Again, thank you everyone for the discussion and all the comments and topics and et cetera. And I'm just glad to be able to present this case.
Thanks, Nick. And thanks, Betsy, as well. Great cases. And definitely everyone, please continue to submit cases, and we'd be happy to have everyone present at out-of-pocket cases. I think sometimes it's something you think, oh, it's, maybe not the most dramatic thing, but it can be just your personal experience, the difference with the patient. Every situation can be different. So there's something for all of us to learn. So please continue to report and submit to be able to present at the out-of-pocket cases. I wanted to give you the CE code for today. I apologize. My system settings security is blocking me, but the code is AGJ176. AGJ176 is the code for the CE. And Louisa also put it in the chat there. Thanks, Louisa. So thank you, everybody. We look forward to seeing you at the next out-of-pocket cases, and please continue to attend and encourage fellow coworkers, fellow EM pharmacists, residents, and everybody to attend, as well as submit their cases to be able to present. Thanks, everybody.